I'd like to focus on four main areas in this talk, which are the main areas, I guess, of gastro-intestinal research that we focus on within AGITG. And as we move through these areas, I'm going to give you some examples of either past or present clinical trials that are or have made a difference to the way that we manage various GI cancers. So firstly, I think I need to explain what is a clinical trial. So a clinical trial is a trial that involves people or humans. However, there is a lot of work that's done before we even get to a clinical trial stage. So basically it's the work that's done in the laboratory, and we call this, I guess, the bench to bedside. So we're relying on our laboratory scientists to use information that has come back through the patients and through other clinical trials to be involved in the development of new medications or treatments. And when something is looking promising, that's when it will be taken into a clinical trial with humans. Now, clinical trials in humans are divided up into four phases. So the first phase of a clinical trial is actually the phase where we have relatively small patients that are involved in the clinical trial, and there may be patients with different kinds of tumours. And in this type of study, we're actually looking to see whether the drug is safe in patients, because it'll be the first time that the drug has been tested in patients, and we're looking to see what kind of dose we can use. If that phase is successful, the patients or the trial will then move into a phase 2 clinical trial, which is often a bigger clinical trial and may often involve a specific tumour stream. So it might be colon cancer, because we've seen some indicators that that particular treatment works better in patients with colon cancer. And in this particular clinical trial, we're looking to see how effective the drug is. So not just whether it's safe and what the dose is, but we're looking to see whether it's truly effective. If we get some positive signals from a phase 2 clinical trial, we then move into our much larger phase 3 clinical trials, which may often involve hundreds, sometimes thousands of patients, may often be in collaboration with many different parts of the world, so researchers in many different parts of the world. And these are the studies that actually lead to the practice-changing treatments. These very large clinical trials are required before a drug usually required before a drug can be registered by the authorities in various countries. So this, as you can see, this is a very long process. So it takes a long time for drugs to get from the bench side to the bedside. And that process does vary, but it can take many years, 8, 10 years. There are processes in place to try and make this process more rapid. So we are looking at the way that our clinical trials are run, the outcomes of our clinical trials, hoping that we can deliver the results from the clinical trials more efficiently so that we can get these very important treatments to the patients much more quickly. The other thing I think that it's important to know that although we all, I think hopefully most people would agree the importance of clinical trials to be able to improve outcomes for our patients, it is sometimes difficult to recruit to clinical trials, so to get patients onto clinical trials for a number of reasons. So firstly, there might not be a clinical trial for the particular patient that you have, or that particular patient might not be eligible, so they might have a comorbidity or another disease that means they cannot go into the study, or their cancer might not be the right stage, or they might have had other treatments that don't make them eligible. So there are lots of specific entry criteria that they have to meet before they can go into the clinical trial. And those entry criteria are designed mainly for safety for the patients, which is obviously the foremost thing that we're thinking about, but also so that we can answer the question appropriately that we're asking of the clinical trial. The other thing is that patients, for doctors, it does take a little bit more work to put patients on clinical trials. There's quite a lot of paperwork and a lot more visits, and generally in a busy clinic we're always trying to think of clinical trials, but sometimes it does go to the back of our mind when we're just trying to make sure that the patient's safe and has their treatment on board. So we have lots of checks and balances, particularly at our institution and hopefully at many institutions, where we can bring that to the forefront of our discussions. We have lists to check off. We check our patient lists before they're coming in, and our registrar also goes through our patient list to see if there's any clinical trial options that we can discuss with our patients. So in Hobart last year, we recruited 100 patients to clinical trials, and we are making a slow increment in the number of patients we get onto clinical trials. And that represents roughly about 9% of all new cancer diagnoses or patients with new cancers being put onto a clinical trial. Now, that is still really low. It's actually better than many other parts of Australia and internationally, where the rates are about 5% of patients entering clinical trials. Many of the cancer bodies around the world suggest we should be aiming for 15% at a minimum. If you look at childhood cancers, 60% of children enter clinical trials, and if you compare the outcomes of diseases in children and the diseases in adults, you'll find that there's been much bigger leaps in the improvements in outcome in children, and a lot of that is because they have much higher participation rates in clinical trials. So we currently have 27 oncology clinical trials open for recruitment at the Royal Hobart Hospital, 5 of which are AGITG or gastro-intestinal clinical trials. And I think since I moved back to Hobart, we've been involved in 15 AGITG clinical trials. So we really like to support AGITG clinical trials. So this is, I guess, summarises the process of clinical research. And as I mentioned, we start with the basic research. This is the laboratory research, and then we translate that information that we learn in the laboratory into our clinical research, which goes through those various phases that I've just discussed. And then once we have that information from our clinical research, we translate that knowledge into clinical practice, so to improve outcomes for our cancer patients. And then the information that we collect in clinics and through registries and all that sort of stuff, we can then feed back to our basic researchers, because questions will come up. For example, we might be using a new treatment and there are some side effects and we're looking to see how they are managed. We might feed that back to our basic researchers and say, look, here, this would be a good idea for a clinical trial. Can you help us in the laboratory? So they're all interrelated. So as Dave mentioned, cancer is a multidisciplinary disease in that we usually involve a number of different people along the journey of a patient with newly diagnosed cancer. And that might not only be doctors, but there's allied health people, our clinical nurse practitioners and specialists and care coordinators, allied health people, exercise physiologists, psychologists, etc. So there's all sorts of people that are involved in a patient's journey. And importantly, AGITG clinical trials involve a collaboration of all of these specialties, the medical specialties including our surgeons, medical oncologists, radiation oncologists, gastroenterologists, plus all of the allied health team, palliative care physicians, everybody. So it has to be studies that are, I guess, meet the needs of all of these people involved in the care of patients with GI cancers. So an example of a multidisciplinary study, which is an AGITG study that has a very cool name according to my 13-year-old son, Top Gear, is actually a study that is looking at patients who have early stage gastric cancer or cancer of the junction between the stomach and the esophagus. Now, in these patients, they have seen a surgeon, and the surgeon feels that he would be able, or he or she, it shouldn't be sexist here, could take that tumour out. However, in this case, we know from previous studies that giving some treatment prior to that operation can improve outcomes. However, there are 2 different treatments, or possibly more than 2, but 2 main types of treatments which have been shown in clinical trials that may be of benefit. Either chemotherapy before the surgery or a combination of chemo and radiotherapy. We don't know which of those 2 options is the best, and various parts of the world do it slightly differently depending on what their preference is. So this study was actually designed to try and answer that question. So we will be able to have, hopefully at the end of this, discussions with our patients to say, well, from this clinical trial, we now know that this is the best option for you if you're looking to have an operation to remove a stomach or gastroesophageal junction tumour. So the total number of patients that we will require, hopefully to answer that question, is about 750 patients over a 5-year period, and we'll then require a follow-up period after that to record the outcomes of our patients, so about 3 years of follow-up. And we're actively recruiting. We've had a number of patients who have already had treatment on this clinical trial. So once again, a very important clinical trial that's bringing together a lot of disciplines, so radiation oncologists, medical oncologists, surgeons, and all of the allied health people that are associated with the care of these patients. So translational research, as I mentioned, this is very important. This is when we translate information that we've learnt into from the laboratory into clinical trials, and also from clinical trials into what happens to our patients in the community. So a very important piece of translational research that was performed by the AGITG, and this is when I was just finishing my training, and Chris Karapetis, who led this study, his picture is there, he does a lot of work in the AGITG. He's from Adelaide also. He was the chair of the study lead for this study in Australia, and this study looked at patients with advanced bowel cancer. And these patients had had many treatments before they went on this study, and they had very few other options left to them at the point when they were considering this study. And what they found in this study is that a drug that Dave's already shown you some information about, called cetuximab, which actually targets the EGFR pathway, and one of these special signalling pathways, was found to be of modest benefit. So it did improve how long patients lived, and it did improve their quality of life in the population as a whole. So all of the patients who were on that arm of the study, so they either got the drug or they got supportive care, because there weren't the standard treatment was supportive care. There were no other options for these patients at that point in time, and they found that the patients who received cetuximab did a little bit better. However, that wasn't enough for these trialists. What they did was, when patients sign up for a clinical trial, there is the option of the trialist being able to use some of the tissue that has been archived. So when people have a biopsy, we never throw any tissue out, or if you have a tumour removed, it's always kept in case we need to use it for clinical research or new tests that are developed, new genetic tests, etc. So about 70% of patients had signed up to have their tissue collected. It didn't involve any more tests for them, but the researchers were able to gather all of those pieces of tissue and do some very fancy genetic tests on the bowel cancers. And what they found was that there was a specific group of patients with advanced bowel cancer that were much more likely to respond to the drug cetuximab. And they were the patients who didn't have a mutation in this particular gene called KRAS. So the patients who did have a mutation were unlikely to benefit, but they got the side effects. So this was a great advance. We could spare the people who are unlikely to benefit from the side effects, and we can give the patients who are more likely to benefit a drug. And we can tell them that this is the chance that you might benefit from the drug. So that test has now become standard for all patients with advanced bowel cancer. We do that on the first day we meet the patients. So a great advance that AGITG has been involved with. Personalised medicine, I think Dave also alluded to this in his talk. This is where we are applying the genetic information that we have to predict either the development of a disease, influence decisions about lifestyle choices, and tailor our treatments to each individual patient. So let's give you an example of, this is another cool name, ice cream. So this is a study which is the idea of an Australian, so Eva Segalov is the main investigator in this study, in collaboration with a number of other investigators around Australia. But essentially what this study is looking at is, once again, the drug cetuximab, which I've just spoken to you about. We know that cetuximab can help those specific patients who don't have the mutation in KRAS when we use it after patients had a lot of treatments for their bowel cancer. We also know if we combine cetuximab with chemotherapy that it can be beneficial when we use it after a patient's had 2 lines of treatment for their bowel cancer. But we don't know whether or not just giving the cetuximab alone or giving it with the chemotherapy is the best option. And we don't want to have to give it with the chemotherapy if we don't have to. So this study is designed to try and work that out. But they did something even better than that. They've actually looked at specific groups of patients who have no mutations in a whole number of genes. So not just that KRAS one we've just learnt about, but also NRAS, PIK3A, BRAF, and all sorts of other fancy names. So they're trying to find those patients that are the most likely patients to benefit from the drug. And that's really personalised medicine. Like the picture that Dave showed, we can actually then pick out those patients and say, look, this is the drug for you. And that would be great, that we would be able to give each patient that we see with cancer a specific drug which is likely to be a benefit to them. So this study started in March 2013, and we are proudly involved in this study. I think we need only 8 more patients Australia-wide to answer this question. So they've done a tremendous effort, and this will be the only study in the world to answer this question. So once again, a pretty amazing effort by AGITG. The other very important focus of AGITG clinical research is survivorship, and this is becoming more and more important as we have more cancer survivors. It's really research that's to understand or better understand the issues that patients have after their diagnosis of cancer when they become survivors. Not that I love that term, but we want to minimise the long-term complications or the late effects that cancer survivors might experience as a result of their treatments they've had in the past or the cancer itself. So an example of a study that unfortunately we weren't able to participate in is a study called the Challenge Study. And this is a study which I think very importantly looks at the impact of physical activity on how long patients live who have had an early stage bowel cancer that has been removed. So after they've had their surgery and they may have had some chemotherapy, they usually then go on to, surveillance, where we see them every 3 to 6 months. They have some blood tests, colonoscopies every few years, and some CAT scans. And we're hoping that they're going to be survivors, but we're looking to see what we can do to improve the outcomes of this group of patients. And we know from lots of observational studies and database studies that exercise is incredibly important in improving outcomes in patients with GI cancer, not just GI cancer, prostate cancer, breast cancer, all sorts of cancers. However, we need a large phase 3 study that actually proves that, so we can take that to the policymakers and the government and say, look, this is what we've found. You need to write policy to make changes so that we have that exercise prescription built in to the treatments for bowel cancer. So this particular study is looking at a structured physical activity program plus provision of just the standard information that our patients get after they've had their bowel cancer removed versus just the standard information that they would get. And they're looking at a number of things regarding things like overall survival, but also the quality of life of patients. And unfortunately, when we really want to do this study, but at that time we didn't have an exercise physiologist to be involved, but maybe next time. So, and I think they're still recruiting, and hopefully they'll have their numbers. They needed, I think, about 1,000 patients to answer that very important question. So, just to sum up, I hope I've convinced you that clinical research is really important if we want to improve the outcomes of patients with GI cancer and, in fact, all cancers. It helps us to understand what's going on, helps us develop new and important treatments. It allows patients, and I probably didn't mention this, to access effective and up-to-date treatment. So I failed to mention that there is another. I went through phase 1, 2 and 3. I forgot to mention phase 4 clinical trials, which we are seeing more of these days. And phase 4 clinical trials are drugs that have already been proven to be beneficial, but we need to gather some more data about, for example, side effects. And those clinical trials are great because they allow patients access to a drug that they may not be able to access because it's not been reimbursed in Australia, and they can get a drug which has already been proven for their cancer. Clinical trials improve standard of care and outcomes for our cancer patients. They better inform future patients, and of course improve individual, community and population health as a whole. So I would like to thank you all for listening to me, but importantly all the patients and their families who've participated in our AGITG clinical trials, and in fact any clinical trial, and the wonderful work that the community do, and of course the GI Cancer Institute do to support this work. Thank you.